Our program is more than just injecting Botox. It's a whole program of having the patient wake up with a dilator. It's the program that we have 2 or 3 days with the patients where they're in recovery, and Ellen and I are counseling them in terms of what to do. I just had a patient that we treated. She'd been to 8 different gynecologists, and nobody gave her the diagnosis of vaginismus. And she went to the internet and typed in painful intercourse and came up with vaginismus and dyspareunia. And I think for me the thing that's the real pity is that oftentimes patients are shunted from therapist to therapist, from psychologist to sex counselor. Nobody knows what to do with them. They go to hypnotherapy, and then they have anti-epileptics and they have antidepressants, and some patients drink themselves into a stupor. Patients very often average 4 to 7 years of therapy.
One of the questions that patients often have is it a painful procedure? Because it's not surgery, people ask about the anesthesia, which is, a concern for them, because if you're having surgery, you're typically under general anesthesia. So knowing that it's a lighter form, maybe you can elaborate on that some more as to...
Yes. So when I start my examination and I want to feel how tight those muscles are, I'll actually do a digital examination, and I'll have coated my glove with some Surgilube and 2% xylocaine.
And the patient is unaware this is happening.
Right. Nobody remembers anything. Once I identify the varying levels of spasm, so most of my patients have spasm at the bulbocavernosum. That's the entry muscle to the vagina, and that's where the patient tells me it's like hitting a wall. They just try to have intercourse, impossible. And then I examine the muscle higher to that, and that's the pubococcygeus, which is the famous PC muscle responsible for Kegel exercises. Interestingly, most of the time, that's not that spastic. Then the highest muscle in the mid-vagina, where some patients can have some penetration, but then it gets stuck in the mid-vagina, which is a smaller percentage, that's the puborectalis. So all 3 muscles are evaluated, and during this period of time, I'm coating the area with topical anesthetic. We put them down further so that they're really in a deeper level of anesthesia, and then I actually inject sensorcaine. So sensorcaine is a long-acting local anesthetic. Generic is bupivacaine, and I use it in all my surgeries. So getting back to this whole area, is it painful? It really isn't, because they have a local anesthetic in there and they have a topical. The Surgery Center is certified. We use American board certified anesthesiologists. Many of the people working in the operating room, including myself and the anesthesiologist, is advanced cardiac life support certified. So it's a very safe experience. And these guys are so good.
They're wonderful.
They are so good that when I say 2 minutes to being done, in 2 minutes that patient is awake. I'm done, and the patient wakes up.
And
the husband or the mother's there the entire time, and they're in the operating room with us so that they can see, that there really is a problem, that it's not just in their head, because even under anesthesia, we still feel the spasm. Even under anesthesia, a patient can be completely asleep, and I go to do a digital examination, the buttocks elevate and retract, the legs want to close up tight, and the patient's asleep.
Completely asleep.
This is profound, that this is actually taking place under anesthesia. And actually, I might add that during the procedure, I do a speculum examination to study the integrity of the vagina and what the compliance is. And I'll start with a little child speculum, and then I'll continue to a medium speculum, and then to a large speculum, and patient after patient, normal vagina. But they wake up with a pretty big dilator in place.
And the party begins.
Right.
That mind-body connection happens.
Yeah.
It is the mind-body
Right.
connection.
So the first day then, we keep them there for the 3 or 4 hours so we can begin working with the dilators. And then they get discharged normally with the purple number 4 of 6 dilator. And then they go home, and they keep that dilator in place for about 36 hours. And we encourage our patients to wear a pair of tight bicycling shorts. Or what are some
Or
of the
tight
things
panties or swimsuit bottoms, something that's snug and comfortable.
Right.
Although we've had a run on, they buy some tighter, lacy things because then it makes them feel better. I just let them know, bring what's going to make you comfortable and be able to work through this muscle recovery. And then the second day when we have them come in, we ask how their dilation went through the evening, and if they were successful, if they were able to move between the number 3 and the number 4 and the number 5, depending on where they were, how long they were able to sleep with it. And then we really spend the second day getting them comfortable with the dilation process and building that confidence that they can go home and do this therapy and continue it and achieve intercourse. Everyone's usually a little more scared about progressing on to the actual active intercourse because they've been avoiding it for so long. So it's really just a confidence builder for them that
Right.
second day, and a more of a bonding experience so that they trust in themselves, not in us, because they already trusted us to come here, but trust in themselves when they leave.
Yes. And this is the beauty of having somebody with us for 2 or 3 days, because we have the time. We have the time to talk about what happens after they go home. What is the best way to dilate? Sleeping with the dilator every couple of nights is important. And I think most importantly is when the patients are leaving after about 3 days, there are a lot of smiles.
There are a lot of smiles.
All that nervousness and, the uptightness is pretty much evaporated. Although we have curtains and we are able to isolate each bed, and very rarely a person will want that level of privacy, most of the time we ask for permission and get permission to just open up the curtains and everybody gets to talk to each other. And so when we do some of our counseling in terms of transitioning from dilators to intercourse, everybody's listening and everybody's chiming in and everybody's asking questions. And there's this bonding that's absolutely incredible. And I would say most often the patients stay in touch with each other by email.
They do most
afterwards.
often. They exchange email, telephone numbers, because it's nice to know that you're not alone. Not only have you found a team that supports you, understands you, but now you found other women who will support you and understand you and are going through the same thing you
Right.
are. So it's really beneficial to them to form their own community. They encourage each other, and that's why we have such a high success rate beyond our help. They help each other to continue to succeed.
And I think this is where we're breaking down the walls of silence, because these are women who just didn't want to talk about it, don't want to talk about it, their families don't know, their husbands don't even know what they've got, and here we're just breaking down the walls and they start feeling more open about it, they're comfortable talking about it, so I think that's all very, very helpful. We certainly welcome you to contact Gloria. Gloria is the first person you'll be making contact with. If you have any questions, any concerns, just contact Gloria. We email each other, and we would look forward to seeing you.
Just know we can help you.